Okay, so today we're going to be going over chapter 12, which discusses the labor and the birth process. Just to start off, we're going to be talking about the 5 P's, which are the powers, the passenger, the passageway and passenger relationship, and psychosocial influences. So to start off, the powers, which are the combination of uterine contractions and maternal pushing efforts. So the contractions are important. They cause the cervix to dilate and also to efface, and that is very important to the birth process. And the pushing efforts obviously aid in the expulsion of the fetus. The passageway is crucial because the baby has to be able to fit through, and as you've heard in the past, some females have very narrow pelvises, and sometimes if they have a really large baby, that may make it difficult for them to have a vaginal delivery. The passenger, obviously, that's the fetus, and that comes into play with what position the baby is in. If you were to look on page 418, they start talking about positioning. So the fetal lie is the relationship between the long axis of the baby and the long axis of the mom. So if you look at the bottom, there's some figures there that kind of give you a visual of what I'm talking about. So longitudinal is ideally what we want. That's where the baby obviously is up and down and their head is coming out first. Transverse is horizontal, and that a lot of times we see with a shoulder presentation, so obviously that is not good. Those babies cannot be born vaginally. A lot of times what they have to try to do is to turn the baby, to try to get the baby to go into that longitudinal position. And then the last one is the oblique. So as you can see from the picture there, it represents the breech presentation, okay? Ideally, we want the baby to be in a vertex, which is the head is presenting first. So that is ideally the presentation that we want. Breech presentation can be either frank, which is the most common, which is the buttocks first. Can also be a footling breech, where it can be a single footling breech or a double footling breech. So the single, obviously, where one foot is coming out. Now those are not ideal. There are some obstetricians that will deliver babies vaginally that way, but there's more risk involved with the breech presentation. Psychosocial influences. Obviously, this goes back to when we've discussed in the past about pain. So if you have a patient that has a traumatic pain experience, then they are going to be having more anxiety and more fear when they have to go through pain again. So if you're taking care of a woman who had a traumatic labor experience previously, she's going to have a lot of anxiety and a lot of fear about going through it again, and that can definitely influence her labor. Okay, there's also cultural or ethnic considerations to keep in mind. So, are they going to be okay with a male OB? Obviously, we would know that. They've been going hopefully to their prenatals, but what happens if their regular woman physician is on vacation or out of town and she only has one partner and he's a male? So this is where cultural and ethnic considerations definitely come into play. Okay, I just wanted to touch on briefly true versus false labor. So obviously this comes into play especially when you're dealing with a prima gravida or a nulliparous, someone who's never had a baby before. So the main difference is cervical dilation. When they are in true labor, the cervix will dilate and it will efface. So changes in the cervix is the indicator of true labor. The contractions become more regular. They last longer, so the duration is longer, and they become more intense as they go along. With the false labor or the Braxton Hicks contractions, and I know we talked about this a little bit last week, they don't have any cervical changes at all. They can be irregular. They're felt more in the abdomen area, And if they get up and take a walk, a lot of times that will resolve them. So, and they don't increase in intensity. They usually feel the same the whole way through. But like I said, if you have a prima gravida, someone who's never had a baby before, they might feel like they're in labor and they may show up to get checked, and that's okay. And that is something that we educate them about, that if you think you're in labor, you need to come in and get checked and see. But really, in the end, the cervical changes are the deciding factor. And remember, Braxton Hicks contractions, they do serve a purpose, as we talked about last week. They prepare the uterus for the labor process. So they are important. They do have a role. Okay, so now I'm going to go through some signs and symptoms of impending labor. That begins on page 422. So we're going to talk a little bit about that right now. So women will experience what we call lightening, where the baby is starting to engage, so the uterus actually drops. You know, when they say you look like the baby has dropped, it actually looks like the baby is lower. So that's when the baby is starting, the presenting part is starting to actually engage into the maternal pelvis. This can cause leg cramps. It can cause pressure on the bladder, which increases urinary frequency. Okay, so Braxton Hicks contractions, obviously we did discuss that, so I'm not going to go through that again. Energy spurt, you know, when they feel like they need to clean and clean and clean and clean, they have so much energy they don't know what to do with it. Obviously the cervical changes, where the cervix is starting to dilate and starting to efface, starting to soften and lengthen. Bloody show, which is the expulsion of the mucus plug. And then, of course, the rupture of the membranes. Now, they can artificially rupture the membranes. That is called an amniotomy. So what they do is they take a tool. The only thing I can compare it to is a crochet hook. And they use that to actually puncture your bag to get the waters to come out. But once they do that, now the mom is at an increased risk of infection, because they don't, the baby doesn't have that barrier anymore. So there is an increased risk of infection, and generally they're going to want that baby to deliver within 24 hours. Okay, so now we're going to kind of go through the stages of labor. So with the first stage of labor, this is generally where they consider that the contractions are becoming more regular, and it ends with the complete dilation of the cervix. So the latent phase is 0 to 3 centimeters, so it's pretty early. The active phase, 4 to 7 centimeters, so somewhere in the middle. And then the transition phase, where it really starts to kick in. They're getting very active. The contractions are really intense. They're lasting longer. They're closer together. This is usually where the mom really gets exhausted and will say things like, I can't do this anymore. I'm so tired. I don't want to do this anymore. The Friedman curve is an assessment tool that labor uses to assess whether or not the labor is progressing normally. That's definitely going to be important, because if there's anything that we need to be concerned about, it needs to be identified fairly quickly. You can see from the picture of this graph, and you can find this graph on page 433 at the bottom, but a multi-parous, someone that's had more than one pregnancy, you can see how much quicker they go through the dilations, but then the nulliparous, you see how much longer it takes by looking at the curve there. It's a very good visual demonstration of the difference between the two. Next, we're going to talk a little bit about fetal assessment. Obviously, this is going to be important to be checking frequently throughout the labor until when we're getting ready for the birth process. We want to know what position the baby is in. Remember, we want them to be ideally to be in that cephalic vertex presentation. But if it's another presentation, if for some reason the baby turned sometime during the labor process and now they're transverse, obviously we need to know that, because then the obstetrician is going to have to try to get that baby to turn. They're going to be checking the fetal heart sounds, so they'll get a baseline fetal heart rate. What is it when the uterus is not contracting? And there can be some variability that can be normal. They can have some accelerations. That is also considered normal. Decelerations are when we start to become concerned. So those are drops in the heart rate in relation to uterine contractions. Okay, so this, you see here, this graph representation, again, it's a visual representation. So the normal heart rate is 110 to 160. And then the bottom picture there at the top, it shows you the uterine contractions. Then if you look at the graph down there on your lower right, you can see the heart rate there. It's about 150, and then it jumps up a little bit, goes to about 160 maybe. That's during a contraction. And then you see here it jumps again. Now the accelerations are okay, and that's definitely something that you want to be educating the mom and dad or the significant other about, that the accelerations are okay. There's not anything to be concerned about. That's just something that they're going to keep watching. Okay, I have a little acronym for you. We love acronyms to help us remember things. So the acronym VEAL-CHOP. Okay, if you spell out those two words side by side, I will talk you through how you work with this acronym. So the V and the C stand for variable and cord. So if the baby's having variable decels, as you can see in that top right-hand corner, that means that for some reason the cord is being compressed, and that's causing some hypoxia. It's causing the heart rate to drop. Now, normally the baby can tolerate some variable decelerations without any problem. That's sometimes natural during the labor process, and that's not really going to be a big deal. If they become more consistent or more frequent, that's usually when the baby may be having a problem. If you go down and you have the H, right, for the CHOP, and you have the E for the VEAL. E stands for early, and the H stands for head. So up in the upper left here, you see a visual representation of early decelerations. That means that there's some pressure being exerted on the head in some way. Now, it could be because of the uterine contractions, and so that's definitely something that they're going to want to keep an eye on. The ones that we get the most concerned about are the late decelerations. They're at the bottom of the page. So the late decelerations usually means that there is something going on with the placenta. If there's something happening with the placenta, remember the placenta is the baby, the placenta and the cord are the baby's lifeline. So if there's something going on with that placenta, then obviously we need to be concerned. And they're late because you see the peak of the contraction there down at the bottom. The bottom of the graph is the contractions. The top of the graph is the baby's heart rate. And you can see how it's dropping after the peak of the contraction. So that's definitely a concern. The A is for accelerations, and the O in the word CHOP is okay. So A, okay. Like I said before, if they're having accelerations, their heart rate's getting quicker, that is okay. It just requires more monitoring. The whole point of monitoring the heart rate patterns is because we're concerned about the baby's oxygenation. Remember that uterus is contracting. Those muscles are causing a squeezing. And when there is squeezing, that's when sometimes their oxygen supply can get cut off. Okay, so in this slide here, we're talking about nursing care. So for the early, they don't really do much. You know, we expect that they're going to have some decelerations. Variable, like I said, babies can tolerate that pretty good, but they do definitely want to monitor them. Late, that's abnormal. Again, we're talking about the placenta. It's insufficient in some way. If they are having late decelerations, we want to change mom's position, maybe put her in a left lateral. They're going to put a 100% face mask on her. If they can check the vag exam, if there's not some contraindication, they're going to do that. If she is getting oxytocin to help to potentiate those contractions, they are going to stop that. They're going to maybe give her some fluids because they are going to anticipate that they're going to have to deliver pretty quickly. So they may give her a 500 or 1,000 liter bolus of lactated ringers. Okay, this discussion is going to continue on the next recording.